Welcome back to the deep dive. We spend a lot of time on this show analyzing complex systems.
We do.
We've looked at the architecture of the internet, the mechanics of global supply chains.
Even the psychological frameworks behind decision-making.
Right, exactly.
Yeah.
But today, we're doing something a little different. We are turning that analytical lens inward.
Completely inward.
Yeah, we're looking at a system that is currently operating under high pressure, 24/7, right under your shirt.
And it rarely gets the credit it deserves.
Never. We are talking about the abdominal wall.
It is quite literally the structural engineering project that holds you together.
Holds everything together.
Right. And I think that is really the only way to properly understand it.
That's exactly the angle we're taking today. I went through this truly fascinating source material. It's a masterclass by Dr. Senthil Kumaran K from the Surgical Thinking Academy.
A fantastic resource.
It really is. And what struck me immediately was the framing of it all. He doesn't talk about the body as this soft biological blob.
No, not at all.
He treats the abdominal wall as a load-bearing partition, like it's a component in a pressurized machine.
Because that is exactly what it is.
He treats it like a piece of industrial architecture. Specific material properties, stress vectors.
And very predictable failure modes.
Yes, predictable failure modes. That blew my mind.
Well, if you view the abdomen purely through a biological lens, a hernia is just, it's just a lump.
Right, just a biological nuisance.
Exactly, a nuisance. But if you view the abdomen as a pressurized cylinder...
Like a containment vessel.
Yes, a containment vessel. Then a hernia becomes a catastrophic structural failure.
A breach in the hull.
It is a breach in the hull. And just like with airplanes or submarines, if you understand the engineering of the hull...
You can predict the breach.
You can predict exactly where the breach will happen before it actually blows.
So our mission for this deep dive is to basically reverse engineer these failures.
We're going to tear down the blueprints.
Right. We want to look at the blueprints of the human abdominal wall, identify the inherent weak points in the design, and understand the physics of why it tears.
And how to fix it.
Exactly. We're also going to get into the clinical reasoning aspect, which honestly felt a lot like detective work to me.
It's very much detective work.
It's about how a surgeon walks into a room, looks at a bump on your stomach, and deduces your entire structural history.
It is detective work, but it's based purely on physics. And the stakes, as we'll see, are incredibly high.
To set those stakes, I want to start with a scenario right out of the source material.
The clinic scenario.
Yeah, because I think it captures the shift from annoyance to emergency perfectly.
Walk us through it.
Okay, so Dr. Kumaran describes a 55-year-old woman presenting at a clinic. She has a midline scar.
Probably from a C-section or maybe a hysterectomy years ago.
Right, and she points to a bulge along that scar. She says it pops out when she strains, like when she coughs.
And then disappears when she lies down.
Exactly.
So stop right there for a second. Structurally, what does that tell you?
That there's a hole.
It tells you there is a defect in the wall, yes. But the containment system is still somewhat functional.
Because it goes back in.
Right. The contents, the intestines or the fat, they can slide in and out. The door is open, but traffic is moving freely.
Okay, so it's a dynamic situation, but a stable one.
Precisely. It's reducible.
But then she drops the other shoe. She tells the doctor it's getting bigger. And last week, it didn't slide back in when she lay down.
It stayed out.
She had to actually push it, and she said it hurt.
And that right there is the pivot point.
The emergency.
We have moved from a reducible failure to an irreducible one. The mechanics have fundamentally changed at that exact moment.
Because the hole is changing.
Well, her saying it's getting bigger implies the material fatigue is accelerating. The hole is widening.
But having to push it.
That means the traffic is jamming. The contents of the abdomen are getting trapped outside the wall.
And that is where the engineering metaphor becomes a very harsh medical reality. If those contents are trapped outside,
They're being squeezed.
they're choking.
We call that incarceration.
Incarceration, like they're in prison.
Literally imprisoned by the abdominal wall. And if the squeeze is tight enough, it cuts off the blood supply.
And that is...
That is strangulation.
Wow.
The tissue dies. The containment failure has now become a necrotic emergency.
Which means dead tissue.
Exactly.
Yeah.
So this isn't just about patching a hole anymore. It is about understanding the dynamics of pressure and flow to prevent a total catastrophe.
Let's go back to the blueprints then. If we are calling this an engineering masterpiece, we need to justify that title.
We do.
Because to me, before reading this, the abdominal wall just looked like I don't know, a slab of meat protecting my digestion.
Most people think of it that way.
But Dr. Kumaran uses a very specific industrial analogy, the cross-ply tire.
It is the absolute perfect analogy for managing multi-directional force.
How so?
Think about a car tire for a second. It is a pressure vessel that holds air, right? But it also has to withstand forces from every single conceivable angle.
Torque when you accelerate.
Yes. Lateral shear when you turn a sharp corner.
Impact when you hit a pothole.
Exactly. So if the rubber fibers in that tire all ran in the exact same direction, say just vertical,
It would fail immediately upon turn.
it would shred. The moment you applied a lateral force, the vertical fibers would just separate and blow out.
It would split along the grain.
Right. And evolution faced the exact same problem with the human abdomen.
Because we aren't static.
We twist, we bend, we lift heavy objects.
We'll cough.
We cough, we sneeze. The internal pressure spikes in random directions constantly.
So the body has to use a laminate design.
Exactly. We have 3 distinct muscle layers on the flank of the abdomen to handle this.
These are the external oblique, the internal oblique, and the transversus abdominis.
Correct. But the genius isn't just that there are 3 layers. It's in the grain of the wood, so to speak.
The direction of the fibers.
Yes. The external oblique fibers run downwards and inward.
Downwards and inwards.
The classic medical mnemonic is hands in pockets. Imagine putting your hands in your front pockets. That's the angle of the external oblique.
Okay, so that layer handles the diagonal vectors going down.
Then the next layer, the internal oblique, runs upwards and inwards.
So perpendicular to the first layer.
Exactly. Perpendicular, it creates a structural crosshatch,
And finally, the transversus abdominis.
which runs transversely,
Uh-huh.
horizontally straight across the belly.
So it literally is biological plywood.
It is a high-tensile composite material. By stacking these grains against each other, you distribute the stress vectors across the entire mesh.
There's no single grain to split along.
None. It allows the wall to be flexible enough to let you breathe and bend over, but rigid enough to hold in your guts under massive internal pressure.
However, as any engineer will tell you, a continuous solid wall is easy to build.
The problem is access.
Right. You eventually have to put holes in it. You need plumbing to pass through, you need access points.
And those access points are the Achilles heel of the entire system.
Dr. Kumaran actually identifies 4 specific categories of weakness.
And I love this framework because it entirely removes the randomness.
Hernias don't just happen anywhere.
They don't. They happen at specific, predictable structural vulnerabilities.
Let's break these 4 categories down, because this seems to be the literal diagnostic checklist the surgeon is running in their head when you walk in.
It's the diagnostic matrix, yes.
Category 1 is natural orifices.
The defects you were born with.
The most obvious one being the umbilicus,
The belly button.
which we tend to think of as a thing, but it's really just a scar, isn't it?
It is the very first scar of your life. It is where the umbilical cord entered the fetus to provide nutrients.
So it was literally a hole in the wall.
A necessary hole. It's a natural gap in the fascial armor that had to be cinched shut after birth.
But because it was once a hole,
It remains a potential failure point forever. It is a permanent discontinuity in the mesh.
fascinating. Now, category 2 is aponeurotic transitions, which sounds like incredibly high-level jargon.
It sounds complex, but it is actually just basic material science.
Okay.
In the abdominal wall, you have muscle, which is red, elastic, and contractile.
It stretches and pulls.
Right. And you also have aponeurosis, or tendon, which is white, rigid, and highly fibrous.
It doesn't stretch.
No. These are 2 completely different materials with different tensile properties.
And joining 2 different materials in engineering is always a massive headache.
Well, like trying to weld aluminum directly to steel.
It's a weak point.
Precisely. The junction point where the red meat transitions into the white sheet is a stress riser.
It concentrates the stress.
The linea alba, that white line running straight down the center of your six-pack, is one of these transitions.
And the linea semilunaris on the side.
Is another one. These seams are naturally weaker than the belly of the muscle itself. They're prone to unzipping.
Category 3 is the one that seems the most frustrating, honestly. Surgical scars.
The man-made weakness.
Why is this one so frustrating?
This is the one that gives every surgeon pause before they pick up a scalpel. Because the rule of the abdominal wall is simple and brutal.
Which is?
Once you cut the abdominal wall, you can never, ever restore 100% of its original tensile strength.
Never. Even if it heals completely perfectly.
Even then, best case scenario, you get maybe 70 to 80% back. A scar is a patch job.
Because the body doesn't weave it back together correctly.
Right. The body lays down collagen to bridge the gap quickly, but it is disorganized.
It's haphazard.
It doesn't have that beautiful, elegant cross-ply architecture we just talked about. It is a stiff, chaotic plug of tissue.
So every incision is a permanent structural downgrade.
Permanent downgrade.
And finally, category 4, acquired weakness. It's like basic system fatigue.
It is the degradation of the chassis over time.
Wear and tear.
Yes. Obesity is a major factor here. It applies a constant, low-level outward pressure on the wall.
Like constantly overinflating that tire we talked about.
Eventually, the rubber fatigues. Chronic coughing is another one from smoking or lung disease.
That's like taking a hammer to the wall from the inside thousands of times a day.
Exactly. Every cough is a massive spike in intra-abdominal pressure.
And what about things like steroids or malnutrition? The source mentioned those.
Those affect the material quality itself at a cellular level. Steroids thin out the connective tissue.
And malnutrition.
Malnutrition means your body literally doesn't have the raw protein building blocks to repair the micro tears that happen in daily life.
So the wall just thins out and gives way.
It degrades until it fails.
So when a patient walks into the clinic with a lump, the surgeon isn't just looking at a lump.
Never just a lump.
They are actively categorizing the failure mode.
We are asking, is this a reopened natural orifice? Is it a failed seam?
Is it a broken scar?
Or is the whole machine just rusting out from acquired weakness? The etiology dictates the repair strategy.
Because if you don't know why it failed, you can't reinforce it correctly.
You'll just put a patch on a crumbling wall and it will fail again.
Let's zoom in on that first category because the source material highlights a really specific area of confusion here.
The belly button paradox.
Yes, the belly button paradox. It seems like a classic trap.
It is a trap for the uninitiated, absolutely.
We see a bulge at the belly button and we immediately call it an umbilical hernia.
Because it's right there at the umbilicus.
But Dr. Kumaran says that is often technically wrong, and actually dangerously so.
It's a critical distinction.
We need to distinguish between a true umbilical hernia and a paraumbilical hernia.
The distinction might sound purely anatomical, but the consequences are highly clinical.
Okay, define a true umbilical hernia.
A true umbilical hernia occurs perfectly straight through the umbilical ring itself, that natural scar we discussed.
And this is primarily a condition found in infants. Right.
Yes. You see it almost exclusively in newborns, especially premature babies.
So the baby cries.
The pressure spikes, and the belly button pops out. It looks terrifying to new parents.
They see their child's insides trying to become outsides.
Exactly. But the engineering perspective here is surprisingly hands-off.
The wait-and-see approach.
Because the machine is still actively building itself. In infants, the abdominal muscles are still developing and moving toward the midline.
As they strengthen and thicken, they pull that ring shut naturally.
The source explicitly notes that 90% of these true umbilical defects close spontaneously by age 3 or 4.
So rushing into surgery would just be superfluous intervention.
It would be unnecessary risk. Unless the defect is massive, say, over 1.5 centimeters, or it persists well past age 4, you let nature do the welding.
Now, contrast that wait and see with the adult presentation. Say, I develop a bulge at the belly button.
If you are an adult, that is almost never a true umbilical hernia.
It's something else.
It is a paraumbilical hernia, para meaning next to.
So the structural failure isn't through the scar itself.
No. It is usually a tear through the linea alba, that central white line, just above or just below the actual belly button.
Why does that geographical difference matter so much? I mean, a hole is a hole.
It matters intensely because of the geometry of the defect.
The geometry.
Yes. Think about the typical adult patient for this, often obese or maybe a woman with a history of multiple pregnancies.
So their linea alba has been stretched.
Stretched thin over years. When a defect forms there, it isn't a soft, pliable ring like in a baby. It is usually a sharp, rigid crack in the fascia.
It has a narrow neck.
A very narrow neck. But the stuff pushing through the crack can be quite large.
Right.
So you have a large volume of fat or bowel actively squeezing through a tiny, rigid slit.
It's like forcing a water balloon through a keyhole.
That's a perfect visual.
Cool.
Once it is through the keyhole, it balloons out on the other side.
And it can't easily slide back in.
It gets trapped. So the risk of entrapment is incredibly high.
Very high risk of strangulation.
The narrow neck acts exactly like a noose. If the bowel swells even a fraction of a millimeter, the blood supply is completely cut off.
Strangulation.
Gangrene. That is why an adult belly button hernia is a surgical target, whereas a child's is not. The physics of the defect are just fundamentally different.
So generally the rule is to fix the adult paraumbilical hernia before it becomes a disaster.
Fix it while it's selective.
But there is a massive stop sign in the source material regarding this.
Yeah.
A specific patient profile where doing that surgery is the disaster.
The cirrhosis warning. This is a critical point of surgical thinking.
Cirrhosis implies advanced liver failure.
Yes.
And liver failure often leads to ascites, which is fluid buildup in the abdomen.
Think of ascites as extreme pathological pressurization. The abdomen is filled with liters of fluid.
So the wall is under immense constant tension.
Immense tension. Now, logically, a junior doctor might think the pressure is pushing the hernia out, so I should just plug the hole.
That seems like the intuitive structural fix. You reinforce the broken wall.
But physiologically, it is a death trap.
Why?
Patients with cirrhosis have two major systemic problems. One, they have coagulopathy.
Meaning their blood doesn't clot.
Their liver isn't making clotting factors, so they bleed uncontrollably on the table.
And problem two.
That fluid pressure. If you make an incision to fix the hernia, you've just created a weak point. The fluid will find that path of least resistance.
Yeah, and it leaks out.
It doesn't just leak, it pours. You get what we call an acidic leak. The fluid forces its way straight through your fresh suture line.
Oh, wow.
It prevents the wound from ever healing. It keeps the incision constantly wet and physically open.
And an open, wet incision directly into the abdomen.
It is a literal highway for bacteria. You are inviting them straight from the skin into the warm, nutrient-rich fluid bath of the abdomen.
You get bacterial peritonitis?
The infection spreads instantly. The mortality rate for an emergency hernia repair in a decompensated cirrhosis patient is staggering.
It's lethal.
Highly lethal.
So clinical reasoning dictates you ignore the hernia entirely.
You deprioritize it. You have to treat the system, not the hole.
How do you do that?
You use diuretics to drain the fluid medically. You fix their clotting factors. You optimize their overall liver function.
Measured by the Child-Pugh score, right?
Exactly, the Child-Pugh score. You only operate when the internal pressure is down and the blood can actually clot. If you rush in blindly to fix a hole, you lose the patient.
It's a stark reminder that as a surgeon, you can't just be a carpenter.
No.
You have to be a plumber and a chemist, too.
You have to manage the entire processing plant, not just the drywall.
Let's move up the torso now. We're looking at the midline still, but higher up, between the belly button and the breastbone.
Ah, the epigastric hernia.
Or, as the source vividly calls it, the fat plug.
The fat plug. It's incredibly common.
This one fascinated me because of the disproportionate pain involved.
The pain is legendary.
We are talking about defects that are sometimes tiny, like millimeter-sized holes.
Sometimes you can barely see them on a scan.
Yet the patient is often in absolute agony. Why does a hole the size of a pen tip hurt more than a massive grapefruit-sized hernia?
It goes right back to the narrow neck principle we just discussed, but on a micro scale.
Explain the anatomy here.
The linea alba in the upper abdomen is a very tight, crisscrossing weave of fibers, but it has to have small natural gaps where tiny blood vessels punch through to feed the fat and skin above it.
Natural perforations for the plumbing.
Exactly. Now, if the weave is just a little bit loose around one of those vessels and internal pressure rises,
A tiny glob of preperitoneal fat gets pushed into that gap.
this is stage 1 of the hernia, just the fat.
It's not even intestine pushing through.
No, just a little yellow nodule of fat. But because the hole is tiny and rigid, remember, it's a tight ring of unyielding tendon that fat gets strangled immediately.
It becomes ischemic,
It loses its blood supply almost instantly.
and dying tissue is painful.
It sends out massive screaming distress signals. The patient feels sharp, burning, localized pain.
But when the doctor palpates the belly,
They might not feel anything at all because the lump is literally the size of a pea.
or it might be buried under belly fat.
Right, so this is a massive diagnostic trap. The patient says it hurts right here, the doctor feels nothing and assumes it's gastritis.
Or a stomach ulcer.
They get put on antacids for months. The clinical reasoning fix here is purely in the physical exam technique.
You cannot just examine the patient lying supine on the table.
Because the system isn't under load, gravity pulls the fat back in.
So you need to pressurize the vessel.
You have to make them stand up. Gravity pulls the fat down into the defect. Then you make them cough or crunch their abs.
You force the pressure up.
You are looking for a trigger point. A tiny, exquisitely tender spot that precisely reproduces their pain when the muscle is tensed.
And the source mentions an iceberg effect here too, which is terrifying.
Yes, the iceberg effect. If you find one fat plug, do not stop looking.
Because there might be more.
The weakness in the fiber wave usually isn't isolated to just one spot. Up to 20% of patients have multiple defects running in a vertical row.
Like a zipper where multiple teeth have skipped.
Exactly. If the surgeon goes in, fixes the one they felt, and ignores the others,
The patient wakes up with the exact same pain.
they do. So you must scan the whole midline.
Always scan the line.
Always.
Let's move from the center to the side of the abdomen. We discussed the layers earlier, the biological plywood.
The obliques.
But there is a specific hernia that exploits a loophole in that layering. The Spigelian hernia.
Ah, the stealth hernia.
Why does it get the stealth moniker?
Because it quite literally hides between the walls. It is an interparietal hernia.
Walk us through the geometry of that, because it's tricky to visualize.
Okay, visualize the 3 layers again. Inner layer is the transverses. Middle is internal oblique. Outer is external oblique.
Got it.
The Spigelian hernia occurs at the linea semilunaris, which is the curved edge of the rectus muscle, or the six-pack muscle.
Right.
In this specific anatomical zone, typically just below the umbilicus, the posterior support is inherently weak.
So the inner wall breaches.
The transverses and the internal oblique tear open. The contents of the abdomen push through those inner doors.
And this is the key to the stealth part.
The outer layer, the external oblique aponeurosis, remains completely intact.
It holds.
It holds firm. So the hernia sac pushes through the inner doors but gets stopped dead by the storm door on the outside.
And it has nowhere to go but sideways.
It flattens out and spreads underneath that strong outer layer.
That is devious. So if I am a doctor looking at the patient's abdomen from the outside,
It looks completely normal. The
Yeah.
skin is flat. There is absolutely no bulge.
because that strong external oblique sheet is holding it down, masking the chaos going on underneath.
It's like a mole tunneling under the top layer of turf in your lawn. You can't see the mole, but the root system is being destroyed.
That is a brilliant analogy. The turf looks fine.
But underneath, it's a mess. The patient comes in with lateral abdominal pain, but there is no lump to guide the doctor.
So they get misdiagnosed again.
Constantly. Doctors think it's a pulled muscle or a pinched nerve or even kidney stones
They get sent to physical therapy.
or orthopedics.
Mm.
Meanwhile, they have a rigid hole in their internal abdominal wall.
And since we established earlier that a rigid hole equals a high strangulation risk,
The risk is incredibly high here. About 25% of Spigelian hernias present as life-threatening emergencies.
because they were completely missed in the elective non-emergency phase.
The bowel gets trapped in that hidden tunnel, swells up, and dies.
So how on earth do you find an invisible hernia?
You have to suspect it. High index of suspicion is the medical term.
You have to be looking for it.
If a patient has point tenderness, specifically at the Spigelian zone, that linea semilunaris, even with absolutely no lump, you don't guess.
You get imaging.
You immediately order an ultrasound or a CT scan. You need X-ray vision to see through the turf and find the tunnel.
It really emphasizes that the physical exam has major limits. Sometimes you just need to look at the blueprints with a scanner.
You absolutely do.
We've covered natural defects and wear and tear so far. Now we have to talk about the failure that the medical system itself causes.
The incisional hernia.
The man-made disaster.
It is the most surgically important hernia we deal with.
The stats in the masterclass were honestly shocking to me. 10 to 15% of all laparotomies, open abdominal surgeries result in a hernia.
It's true, and up to 20% for midline incisions over a 10-year period.
That is a staggering failure rate.
Yeah.
I mean, imagine if civil engineers built bridges that collapse 20% of the time within a decade.
There would be congressional inquiries.
People would go to jail.
But in surgery, because we are dealing with biological tissue that varies wildly from person to person, it has historically been accepted as just a complication.
But is it really just the patient's tissue? Or is it how we are building the bridge?
It is definitively both. We know the patient factors, obesity is the ultimate enemy of wound healing.
It puts constant tension on the fresh suture line.
Exactly.
Yeah.
Infection is the other massive factor. Bacteria secrete enzymes that literally dissolve collagen.
So if a wound gets infected,
The structural integrity plummets, creating a 50% chance of a hernia forming later.
but the source material focused heavily on the surgical technique itself, the actual physics of the stitch.
This is where the STI-TCH trial comes in. It completely revolutionized how we close abdomens.
Before this, it was just guesswork.
The debate was vague. Everyone had their own favorite way to sew. But the STI-TCH trial gave us a hard, evidence-based engineering rule.
The 4-to-1 rule.
The 4-to-1 rule.
Break that down for us. What are the variables in that ratio?
It is the strict ratio of suture length to wound length.
Suture being the thread.
Right. If you have a 10-centimeter incision on the abdomen, you must use at least 40 centimeters of thread to close it.
Okay, that sounds really counterintuitive to a layperson. My instinct says tight is right, pull it as shut as possible. Why do we want so much extra thread in the wound?
Because of the cheese wire effect.
Oh, that is a visceral image.
It is a painfully accurate one. Think about it. If you use a short thread and take big, wide bites of tissue on either side of the cut,
And then you pull it tight.
all the mechanical tension is concentrated at the microscopic points where the thread enters the fascia.
The pressure points.
Right. Now, when the patient coughs or moves, the abdominal tissue swells and expands.
But the thread doesn't stretch.
The thread is static, so it cuts. It mechanically slices right through the muscle, just like a steel wire through a block of cheddar cheese.
And once it slices through.
The wound opens internally. The hernia begins on day 2.
So how does the 4-to-1 rule stop the cheese wire?
It mandates a technique called small bites. You take very small bites of tissue, only 5 to 8 millimeters from the edge.
And you place the stitches very close together.
5 millimeters apart. This packs a massive amount of thread material continuously into the wound.
It distributes the load over a huge area.
Exactly. It essentially creates a spring-like effect. The continuous loops of excess thread can absorb the kinetic energy of a cough or sudden swelling.
Without cutting into the tissue.
It creates a dynamic tension rather than a static strangulation. The thread gives a little so the tissue doesn't tear.
So it's very tedious work, lots of tiny repetitive stitches, but it literally saves the wall.
It cuts the hernia rate significantly. It is the fundamental difference between actually welding a seam and just taping it shut and hoping for the best.
Now what happens when we fail? When an incisional hernia is ignored or fixed poorly and gets completely out of control.
This is where we talk about loss of domain.
Loss of domain. It sounds like a medieval king losing his lands.
It's the nightmare scenario. This is the end-stage terminal failure of the machine.
Does it mean the abdomen loses its rights to the organs?
In a very physical way, yes. Imagine a patient who has had a massive, untreated incisional hernia for a decade. A huge portion of their intestines, maybe half their bowel, has been residing entirely outside the abdominal wall, hanging in a giant sac under the skin of their belly.
They're living outside the main building.
Right. Now, nature abhors a vacuum. Since the main abdominal cavity, the room inside the muscles, is now half empty, it shrinks.
The muscles contract.
The abdominal wall muscles contract inward. The diaphragm lowers. The actual physical volume of the abdominal cavity drastically decreases.
The domain is lost.
The 3-bedroom apartment has been downsized to a studio.
In the tenant, the massive pile of intestines is now too big to move back in.
Precisely. And this presents a potentially lethal physics problem for the surgeon.
Let me guess. If a surgeon just blindly forces those intestines back into the shrunken cavity,
and sews the wall shut tight over them, what happens to the internal pressure?
it must spike off the charts, like overpacking a suitcase and sitting on it.
It causes a condition called abdominal compartment syndrome.
Compartments.
The pressure inside the belly becomes so high that it exceeds the pressure in the venous system. It physically collapses the inferior vena cava, the main vein returning blood to the heart.
So blood can't get from the legs back to the heart.
Which means cardiac output completely drops.
The heart is pumping on empty.
Simultaneously, that immense pressure pushes the diaphragm up into the chest cavity.
So the lungs can't expand.
The patient creates a hypoxic failure. They can't ventilate, and it crushes the delicate renal veins, so the kidneys instantly fail.
It's a multi-system crash.
It is fatal.
So you simply cannot fix the hernia directly. The surgery itself would kill the patient.
You have to remodel the building first. You have to expand the domain before you can return the organs.
How do you even do that?
We use advanced techniques like progressive pneumoperitoneum.
What is that?
We insert a small catheter into the abdomen and literally pump ambient air into the cavity every single day for weeks before the surgery.
You slowly blow the balloon back up.
We stretch the muscles out over time, actively creating space. We also use chemical denervation.
Like Botox?
Exactly like Botox. We inject botulinum toxin into the lateral oblique muscles to temporarily paralyze them.
So they relax and lengthen.
It is a massive, multi-stage engineering project just to get the patient to a baseline state where the final surgery is survivable.
It really drives home the point that the abdomen is a perfectly balanced system in equilibrium.
It is highly tuned.
You mess with the volume to pressure ratio, and the whole thing collapses.
It is not a suitcase you can just stuff clothes into. It is a closed hydraulic system.
Before we wrap up today, I want to touch on this section Dr. Kumaran explicitly calls the guaranteed viva questions.
The zebras.
These are the rare hernias, the ones that medical students sweat over.
They sweat over them for good reason. They are rare, but they are crucial because they are so easily missed in clinical practice.
Let's start with the lumbar hernias. Hernias literally coming through the back.
Yes, through the posterior abdominal wall. There are two specific anatomical triangles of weakness in the thick back musculature.
The superior and inferior triangles.
Superior is called the triangle of Grynfeldt. It's located high up, right under the 12th rib.
And the inferior?
The inferior is the triangle of Petit, located lower down, just above the iliac crest of the hip bone.
And how do these present? Just a lump on your back?
A soft lump in the flank. They are quite rare, but if a doctor hastily mistakes them for a simple lipoma, a benign fat lump, or maybe a kidney tumor, they might be in for a very nasty surprise when they cut into it in a minor surgery room.
Because there's bowel right under the skin.
Exactly. But the real diagnostic challenge, the true Sherlock Holmes moment of the masterclass, is the obturator hernia.
The source calls this the forgotten hernia.
It is arguably the most lethal hernia we deal with on a percentage basis. It has an incredibly high mortality rate.
Why is it so deadly? Is it the anatomy or the delay in finding it?
It is the absolute invisibility of it. It occurs incredibly deep inside the bony pelvis.
Where exactly?
There is a small natural hole called the Obturator canal, where specific nerves and blood vessels pass through the pelvic bone down into the leg.
So if a piece of bowel gets stuck down there...
It is trapped deep inside the core of the body. There is absolutely no external lump to see or feel on the abdomen.
Who usually gets this?
The classic patient profile is an elderly, very thin woman who has recently lost a lot of weight.
Why does weight loss matter?
Because the canal is usually plugged by a protective fat pad. When she loses weight, the fat pad shrinks and the canal opens up, allowing the bowel to slip right in.
So she comes into the ER vomiting with a full bowel obstruction.
Right. She's incredibly sick, but when you examine her belly, it looks perfectly fine. Soft, no scars, no lumps.
So the doctors are completely puzzled.
Diagnosis is severely delayed. They assume it's severe gastroenteritis or maybe an occult cancer.
Meanwhile, the bowel is strangulating deep in her pelvis.
Dying by the hour. But there is a sign, a very specific, brilliant physical test.
The Howship-Romberg sign.
Yes. This is pure deductive anatomical reasoning. The hernia sac containing the trapped bowel shares that tiny pelvic canal with the obturator nerve.
The nerve that goes to the leg.
Exactly. So if you take the patient's leg and actively rotate the hip internally,
You twist the leg inward.
that specific mechanical motion stretches the obturator nerve directly against the swollen hernia sac.
It rubs against it.
It severely irritates the nerve.
And where did that nerve send its pain signals?
Straight down to the inner thigh, all the way to the knee. So if you twist the hip and the patient suddenly screams in agony, not in their belly, but in their inner thigh.
That is a positive Howship-Romberg sign.
Inner thigh pain is the flashing red siren that the bowel is rotting inside the pelvis.
That is a brilliant piece of deduction.
If you know that specific sign, you can rush them to the OR and save a life. If you don't know it, you miss the diagnosis entirely, and the patient often dies.
We have covered a massive amount of ground here today.
Yeah.
From the cross-ply tire of the healthy abdominal wall, all the way to the catastrophic systemic failure of loss of domain.
It's a journey through biomechanics.
If we have to distill this surgical thinking for you, the listener, what are the core pillars to walk away with?
I think there are 4 main undeniable takeaways from Dr. Kumaran's masterclass. Number 1 is simply anatomy is destiny.
The abdominal wall isn't random.
It fails at highly predictable transition points. The belly button, the linea alba, the surgical scars. If you truly know the layers, you understand why the failure happened.
Right. What's number 2?
Number 2, context is king. A belly button hernia in an infant is a self-correcting wait-and-see issue.
But in an adult,
In an adult, it is a narrow-necked trap waiting to spring. And remember, a tiny, exquisitely painful lump like the epigastric fat plug is often far more dangerous than a massive, painless one.
number 3.
Engineering over brute force. The 4-to-1 rule for closing incisions. Small bites, highly distributed tension.
That is how you prevent the cheese wire effect.
Exactly. That's how you stop incisional hernias before they even start.
And finally, number 4.
Respect the pressure vessel. The concept of domain.
You can't ignore the physics.
You cannot treat a massive hernia like a simple hole in a wall if the equilibrium of the entire container has shifted. You have to respect the internal volume and the pressure dynamics, or you will cause a systemic fatal crash.
The source material actually leaves us with a massive cliffhanger for part 2 of the class. It asks a provocative question about that advanced reconstruction.
Yes, it leaves you thinking. It asks, when the domain is lost and the gap in the muscles is too wide to simply pull closed, how do we use a technique called component separation to actually slide the layers of the wall over each other?
Surgical geometry. Literally unlaminating and sliding the layers of plywood to cover the massive hole without increasing the tension.
It is essentially borrowing structural length from one area of the body to pay a critical mechanical debt in another.
But that is a highly complex engineering discussion for another day.
It certainly is.
Well, I will definitely never look at my own abs the same way again. They feel far less like a vanity gym project now, and much more like a high-tension suspension bridge that I desperately need to maintain.
That is exactly what they are. Keep your internal pressure manageable, avoid the acquired weaknesses, and if it ever breaks, hope your structural engineer knows what they are doing.
Very sound advice. Thanks for listening to this deep dive. We will catch you on the next one.